بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا يا أكرم الأكرمين. Dear colleagues, now we will handle one of the important topics. It can be included in the series of the brain imaging, but I prefer to include this topic in the head and neck imaging. It will deal with imaging of the cell. This is actually a very long subject, and we will handle it on two parts. The first part will deal with the intracellular pathology as well as the anatomy of the pituitary gland, and the second part will deal with the rest of the related areas like the supracellular pathology and the paracellular pathology. You know that the bony cella is depression or the fossa in the cellular floor in the skull base, and it is about 16 millimeter in the anteroposterior diameter and 14 millimeter in depth. The contents of the pituitary fossa are the pituitary gland, part of the pituitary stalk, as well as CSF. And this CSF is normally present within the cella, and I want to say that because sometimes whenever you see some CSF inside the cell and you think that this is an empty cell. No, but the diagnosis of empty cell will depend on some of the facts that I will mention very soon. And how to examine the cell by CT? We should have the axial and coronal planes. Then we usually scan the pituitary area every 2 or 3 millimeter scan intervals, and this is the plane of scanning in the axial image. In the axial plane, the patient is supine, the scanogram is lateral, and you have the line tangential to the cellular floor, and you end your exam by reaching the supracellular area. Then in the coronal plane, the patient is prone, and you start scanning from the just a little bit behind the dorsum celli, and you proceed anteriorly until you finish the area of the pituitary fossa, and you reach beyond the anterior clinoids. Nowadays, with the use of multi-detector CT, we do not usually have these true coronal scans, but we can reconstruct the images, the axial images. We can reconstruct these images into the coronal plane and also in the sagittal plane. And then you should display the images in bone and soft tissue window settings, and you select a suitable field of view in order to show the pituitary fossa and the pituitary region at maximum. Don't miss any of the related structures, and do not include two other structures that are not important in the field. In many times we need to inject the patient with intravenous contrast, and in most of the head and neck imaging we should ensure the symmetric position of the patient during scanning. This is an example of an axial image through the pituitary fossa, and this is the coronal image. You should know that the coronal plane is one of the most important planes for evaluation of the pituitary gland, both in the axial and both in the CT and MRI. And this is the normal appearance of the pituitary gland by MRI T1 weighted image after intravenous contrast injection. You see that the pituitary gland is is concave from its superior border, and a little bit convex from its inferior border. It is connected by the infundibular stalk to the region of the hypothalamus, and this infundibular stalk is almost always located in the midline plane. And here you can see the optic chiasm, which is the decussation of the optic nerves, and on both sides of the pituitary fossa you can see the cavernous sinus, and a prominent structure within the cavernous sinus is the internal carotid artery, which shows a signal void appearance due to the flow inside, and this represents the clivus, which is usually containing bone marrow, and the marrow contains fat, and that's why the clivus is bright in this T1 weighted image. Then the pituitary gland in the sagittal image. Here you can in many times separate the posterior pituitary from the anterior pituitary, especially if you have the scans before injection of contrast media. Then this is the pituitary stalk, and I will mention the details of the suprasellar anatomy later on. Then you can see here some of the CSF inside the pituitary fossa. This is the sellar floor, and this is the dorsum celli, and you can appreciate the difference between the posterior pituitary and the anterior pituitary. Here is once more the region of the clivus, and this is the sphenoid sinus, of course. Then this is the optic chiasm, and this is the mammillary body. I will explain this in full details after that. Then in order to have an MRI scan of the pituitary gland or the region of the sella, we usually obtain the scans at 3 millimeter slice thickness. We usually have the sagittal and the coronal T1 weighted images before and after intravenous contrast injection, and also we have an axial T2 or FLAIR images for the brain. And as I will mention after that, we also include the dynamic study in the coronal plane, which means that we rapidly scan the area of the pituitary gland after injection of a bolus of contrast media, so that we can differentiate the enhancement of the pituitary gland from other lesions occurring inside the gland itself. And this is the normal appearance of the pituitary gland. You can appreciate the normal size and shape of the sella. You should ensure that the upper border of the pituitary gland is concave, especially in the coronal plane, and it may look flat in the sagittal plane. Then whenever you inject contrast medium, you expect that the pituitary gland will show homogeneous contrast enhancement, so that you can not usually discriminate between the anterior and posterior pituitary. The normal height of the pituitary gland is usually less than 8 millimeter. The distance between the sellar floor and the top of the pituitary gland is less than 8 millimeter. The infundibular stalk is located in the midline as seen in the coronal images, and the suprasellar cistern contains CSF, as you can see here. Then if you have the sagittal images before injection of contrast media, you can differentiate easily between the posterior pituitary and the anterior pituitary, because the posterior pituitary contains more fat and more triglycerides. Then it will appear brighter than the anterior pituitary. And this is the way to discriminate between both, and the discrimination is sometimes important, as I will mention. Then these are the hormones that are produced by the anterior pituitary, which is known as the adenohypophysis, and which represents about 75% of the pituitary volume. The posterior pituitary, or the neurohypophysis, is about 25% of the pituitary volume. It can be easily discriminated in the sagittal images before contrast injection. The posterior pituitary, or the pituitary gland, is connected through the infundibular stalk to the region of the hypothalamus. And actually, the hypothalamus is not a structure that you can put your finger on it on the images, but you can appreciate its existence by certain anatomic landmarks. The hypothalamus is composed of too many nuclei, which are important in production of some of the hormones. Then they are delivered to the pituitary gland, or control the action of the pituitary gland via the infundibular stalk. This is the normal appearance of the pituitary gland. The posterior pituitary is brighter than the anterior pituitary in the sagittal T1 weighted images before injection of contrast. Then, as I have mentioned, we will deal with the pituitary, the cellular imaging from 3 anatomic regions. The lesions occurring inside the pituitary fossa, lesions above the pituitary fossa occurring in the suprasellar area, and lesions occurring on either side of the pituitary fossa that are involving the region of the cavernous sinus. And we have discussed the infracellular pathology whenever we discussed the imaging of the paranasal sinuses. And you know, the cellular floor is intimately related to the roof of the sphenoid sinus. Then here are the lesions which we are going to discuss. We mentioned something about the anatomy. Then we mentioned some of the congenital lesions, how to diagnose empty sella, and what about the pituitary cysts. Then what about the pituitary adenoma, microadenoma, macroadenoma, hemorrhagic adenoma, invasive pituitary adenoma, then Rothig's cleft cyst, and intracellular metastatic deposits. Then one of the known congenital anomalies or congenital lesions of the pituitary gland is the ectopic location of the posterior pituitary. Here, this is the normal posterior pituitary seen in the pituitary fossa posterior to the adenohypophysis. But in this particular example, you can see that the posterior pituitary is ectopic and is intimately related to the upper part of the infundibular stalk. The stalk itself is hardly appreciated, and this is one of the anomalies. It's a small or even absent pituitary gland or the stalk. Ectopic neurohypophysis existing in the suprasellar area, and sometimes the pituitary stalk is duplicated. And this is an example of a hypoplastic pituitary gland and the thread-like infundibular stalk. And you look here and you can see this is the infundibular stalk, which is very fine, and this is the pituitary gland, which is relatively smaller. Then, and if you look superiorly near the end of the infundibular stalk, and you can see the posterior pituitary, which is ectopically located. Then the empty sella means that there is excess of CSF inside the pituitary fossa, and this is considered of 2 types: the primary type and the secondary type. The secondary type is usually the sequelae of excision of the pituitary gland, or a tumor involving the pituitary gland, resulting in more CSF in the pituitary fossa. But in the primary type, the pituitary gland is there, but it is flattened against the cellular floor, and most of the pituitary fossa is filled with CSF. The fossa may be sometimes enlarged, and the most important sign for the diagnosis of empty sella is that identification of the infundibular stalk dipping inside the sella below the level of the posterior clinoids. Usually the infundibulum is attached to the upper surface of the pituitary gland at the level of the posterior clinoid. But in cases of empty sella, the CSF is increased, the pituitary gland is flattened, and the infundibular stalk is seen going deep inside the pituitary fossa. And in the axial images, you cannot appreciate the possibility of empty sella, since normally you can see the infundibular stalk surrounded by CSF. But in the sagittal and in the coronal planes, if you see that the infundibular stalk is dipping inside the sella below the level of the posterior clinoids, then this is an empty sella. And this is also another example. In the sagittal image, you see the infundibular stalk going deep inside the sella, and also in the coronal image, the sella is mostly filled with CSF. Then sometimes you are confronted by a small lesion within the pituitary gland, and this lesion is not usually enhancing. And here is an example. Then you see this very small, well-defined lesion which is located within the enhancing pituitary gland. The main differentiating points are pituitary cyst, pituitary microadenoma, and Racic's cleft cyst. The Racic's cleft cyst, which is a cyst arising from the nasopharyngeal duct, as I will mention, this cyst is classically located in the midline below the level of the infundibular stalk. This is one of the typical locations of the Racic's cleft cyst whenever it is small. But according to the clinical picture and laboratory findings, you can differentiate the cyst from the pituitary microadenoma. Sometimes you are able to do this, but we used to diagnose lesions within the pituitary gland as microadenomas until proved otherwise. And if you look here, and you can see this is the pituitary gland, which is somewhat flattened, and there is a small lesion which shows bright signal in the T1 and the bright signal in the T2. Then this may be considered hemorrhage in a pituitary microadenoma or hemorrhage in a cyst because of the brightness in both T1 and T2 weighted images. The two main types of pituitary adenoma are the microadenoma, which is by definition a lesion that is less than 1 centimeter in diameter, and the pituitary macroadenoma, which is a mass measuring more than 1 centimeter in diameter. Then microadenoma is a small lesion less than 1 centimeter in diameter. It may involve one of the sides of the pituitary gland, like the left side or the right side, or maybe in the midline exactly below the level of the infundibular stalk. Most of the pituitary adenomas will show intermediate signal on the T1 and intermediate signal in the T2 weighted images, but sometimes you can see that the adenoma will show intermediate signal on T1 weighted image being not discriminated from the pituitary tissue before contrast injection, and it may show bright signal in the T2 weighted image, but whenever you inject contrast, some of the pituitary adenomas do not show significant enhancement compared to the normal enhancement of the normal pituitary gland. Then this is a classic appearance of a pituitary microadenoma occurring in the left side of the pituitary gland. This is the left cavernous sinus and internal carotid artery within the cavernous sinus. And also here, before contrast injection, you are not able to discriminate a focal lesion within the pituitary gland, which is relatively prominent with convex upper border. But after injection of contrast, you can see this non-enhancing or relatively less enhancing lesion within the left side of the pituitary gland. And this is also another example. In the pre-contrast scans, you can see there is some contour deformity of the upper border of the pituitary gland on the right side. After contrast injection, then you can see that there is a lesion which is not enhancing compared to the enhancement of the normal pituitary tissue. This is the normal serum level of the prolactin, and the elevation of the prolactin above this figure is almost diagnostic of a pituitary microadenoma. Then in this example, which is a coronal T1 weighted image after contrast injection, you can see a pituitary microadenoma occupying the right side of the pituitary gland, slightly displacing the infundibular stalk to the left side, and this is of course the optic chiasm and the suprasellar area filled with CSF. Then sometimes you got hemorrhage inside the microadenoma, and this will result in elevated signal of the microadenoma in the T1 and T2 weighted images, and you see the bright appearance of the pituitary microadenoma on the right side. And before the era of MRI, we had some CT criteria for the diagnosis of pituitary microadenoma. This CT criteria included the focal non-enhancing lesion within the pituitary gland, like this lesion. You see, this is the pituitary infundibular stalk, and this is the microadenoma, or surface bulge of the pituitary gland, like this, what we call contour deformity of the superior aspect of the pituitary gland, which indicates that there is a pituitary microadenoma here. But convexity of the upper border of the pituitary gland is not considered a reliable diagnostic sign, since it can be seen normally in some adolescent females, for example, and also it can be seen in cases of pituitary hyperplasia. Also, contralateral deviation of the pituitary stalk, meaning that if there is a pituitary microadenoma on the left, it may displace the stalk to the right, but you can appreciate that this is a weak sign, because here is an adenoma and the stalk is in the midline. Then because of the greater sensitivity of the dynamic study in MR imaging of the pituitary gland, it is now considered as a routine part of the protocol of pituitary imaging. By dynamic study, we mean that we inject the contrast medium, gadolinium, as a bolus, and we scan rapidly the pituitary gland in order to appreciate the difference between the pituitary gland, the enhancement of the pituitary gland, and the enhancement of the pituitary microadenoma. And this is the usual study. And we have the pre-contrast, when you inject contrast, and we have the scan post-contrast. Then if these scans are not in the dynamic phase, you got homogeneous enhancement of the pituitary gland, and you cannot discriminate a lesion within the pituitary gland. But if you look here, and this these are selected images from a dynamic study. We inject contrast and we scan rapidly the pituitary gland. And we know that the pituitary gland enhances more rapidly than the pituitary microadenoma. Then by the dynamic study, you have the chance to detect a less enhancing lesion within the pituitary gland representing a microadenoma. While if you wait for some time, you got homogeneous enhancement of the pituitary gland and you are not able to discriminate any focal lesion inside. Then the dynamic contrast enhanced MRI is one of the tools for better detection of pituitary microadenoma. And if you look carefully here, and this is the pituitary gland, but on the left side you can see this deformity which affects the superior surface of the pituitary gland adjacent to the cavernous sinus, representing a microadenoma. And then sometimes the microadenoma do not cause pituitary surface bulge, because the microadenoma is actually located near the sellar floor, and this was sometimes considered a sign of pituitary microadenoma whenever you see homogeneous enhancement of the pituitary gland and the depression in the sellar floor, which may be related to the site of the pituitary microadenoma. But here you see that the pituitary gland is almost homogeneously enhanced, but in the MRI you can appreciate the difference between the enhancement of the pituitary gland and the pituitary microadenoma. And then we came to the macroadenoma, which is a large lesion more than 1 centimeter in diameter, occupying the pituitary fossa, and many times it extends in the suprasellar area, affecting the suprasellar structures. This lesion is usually homogeneously enhanced, but if it is large, it may show heterogeneous enhancement and may contain cystic changes. It also may show calcium, but the calcium here is relatively rare, and the hemorrhage inside the pituitary adenoma is a well-known phenomenon. Then here, this is an example of MRI of pituitary adenoma. This adenoma is big, and it occupies the pituitary fossa, and it is seen extending a little bit into the suprasellar area, as you can appreciate this from the coronal image. And this is a sizable pituitary adenoma. The pre-contrast coronal T1 and the post-contrast coronal T1 weighted image shows a big pituitary mass, and this mass is occupying and expanding the sella with extension into the suprasellar area that has compressed and flattened the optic chiasm, as well as indented the region of the hypothalamus. And here you can appreciate the internal carotid arteries within the cavernous sinus. The arteries are patent as judged by the signal void appearance. And some of the pituitary adenomas may show heterogeneous appearance and may contain cystic changes, which are seen in about 5 to 18% of the cases. And this is the axial images of a CT scan post-contrast of the pituitary region, showing a pituitary macroadenoma extending well in the suprasellar area, and this suprasellar extension can be appreciated more in the coronal images. MRI T1, T2, and T1 post-contrast of a patient with pituitary adenoma. You see the adenoma filling the sella and extending in the suprasellar area, obliterating the CSF space and touching the inferior aspect of the optic chiasm. The lesion showed intermediate signal in the T1 and also intermediate signal in the T2 weighted image with almost homogeneous post-contrast enhancement. Then whenever you are going to diagnose a pituitary macroadenoma, what you should mention in the report. And here you should identify the different extensions of the lesion, especially in the suprasellar area. And you should state that if the pituitary gland has filled the suprasellar cistern, have reached the chiasm or compressed the chiasm, have reached the hypothalamus or compressed the hypothalamus. This is considering the suprasellar extension. Then you go to evaluate the extension into the parasellar area, infiltrating the region of the cavernous sinus, which is a very important issue to be mentioned in the report. Then the pituitary gland may also invade the sellar floor and extend into the sphenoid sinus. And finally, you assess the presence of intratumoral hemorrhage. Then, considering this pituitary adenoma, and this is T1 and this is axial T2 and this is T1 post contrast. Then here you see that the adenoma has filled the sella, has extended into the suprasellar area, reaching the undersurface of the optic chiasm, which is a little bit elevated. But in the post-contrast study, you can see that there is a component on the left side has compressed the optic chiasm and also indented the region of the hypothalamus. Then the suprasellar extension of the lesion has passed through the three main anatomic areas: the suprasellar cistern, the optic chiasm, and the hypothalamus. On the parasellar extension is assessed by the appearance of the internal carotid artery inside the cavernous sinus. The most sure sign of cavernous sinus invasion is the detection of tumor tissue lateral to the internal carotid artery, like in this case. You see, this is the carotid artery. You see a good part of the tumor lateral to the internal carotid artery on both sides, meaning that the cavernous sinuses have been invaded by the pituitary adenoma. And one of the important issues here is that the adenoma is usually do not affect the internal carotid artery. The artery caliber is maintained without encasement, narrowing, or occlusion. Then if you see that the adenoma is of bright signal in the T1 weighted image, and you know that there is hemorrhage inside the pituitary gland. And in this particular situation, you have to discriminate this from the craniopharyngioma containing high signal fluid in the T1 weighted image of its cystic component. And this I will mention in full details whenever I am handling the suprasellar area. Then look here in this example, there is a pituitary macroadenoma that has extended into the suprasellar area, compressed the optic chiasm, and also compressed the hypothalamus. On the right side, you can see the tumor tissue lateral to the internal carotid artery, and this is diagnostic of right cavernous sinus invasion of the pituitary adenoma. But on the left side, you can see the internal carotid artery within the cavernous sinus, but you cannot see an enhancing tumor tissue lateral to the cavernous sinus, meaning that this pituitary adenoma has invaded the right cavernous sinus, but not the left cavernous sinus. Then this is the difference between the pituitary adenoma whenever extending into the cavernous sinus and the meningioma whenever involving the region of the cavernous sinus. I have mentioned that the pituitary adenoma do not affect the caliber of the internal carotid artery nor its patency, while meningioma is usually associated with cuffing of the vessels and the attenuation of the lumen. And this is one of the differentiating points. There are too many differentiating points between both. I will mention in the part of the parasellar imaging. Then this is a very big pituitary adenoma that has extended into the suprasellar area and compressed the optic chiasm, reaching the region of the hypothalamus. And there may be invasion of the sellar floor with extension into the sphenoid sinus as well. This is an example of hemorrhagic pituitary adenoma, sagittal T1 and coronal T1 weighted images. And you can appreciate the bright signal of the hemorrhage within the pituitary adenoma, which is big enough to reach the region of the hypothalamus. There is no invasion of the cavernous sinus region bilaterally. And this is the axial T2 weighted image of the brain, showing the brightness of the hemorrhage inside the pituitary gland. An invasive adenoma, by definition, is that adenoma that instead of going in the supracellular area, it destroys the cellular floor and extend into the sphenoid sinus. And if you see an adenoma which is eroding the cellular floor, extending into the sphenoid sinus, then you can call this an invasive pituitary adenoma. This is a very big pituitary adenoma occupying the region of the pituitary gland and extending into the supracellular area, reaching the optic chiasm, and also invaded the cavernous sinuses bilaterally. You see the tumor tissue lateral to the internal carotid artery on both sides, and it has also invaded the skull base, filling the region of the sphenoid sinus and bulging into the nasopharynx as well. There is destruction of the clivus and encroachment on the prepontine cistern. And this is also an example of invasive pituitary adenoma with somewhat extension into the supracellular area, but a bigger extension into the infracellular area, obliterating the cavernous sinus. Then the adenoma which is extending into the supracellular area with intact cellular floor, and this is known as the pituitary microadenoma. But whenever the adenoma is invading the cellular floor, extending into the sphenoid sinus, and this is invasive adenoma. In this adenoma, you can see obliteration of the supracellular cistern, compression of the chiasm, as well as the hypothalamus. Considering the paracellular extension, looking at the internal carotid artery, you cannot see the tumor tissue lateral to the internal carotid artery, meaning that there is no cavernous sinus invasion. Some of the lesions which may be mistaken for pituitary adenoma, and this is one of them, is the pituitary abscess. And in many cases, they usually say that the pituitary abscess is usually the sequelae of operations like the transsphenoidal approach for removing pituitary microadenoma or macroadenoma. But in fact, you cannot be able to discriminate this non-enhancing lesion within the enlarged pituitary gland, whether it is an abscess or it is a pituitary adenoma. And sometimes the symptoms of the pituitary abscess is almost similar to those of the adenoma rather than infection. And the abscess, as you know, all over the body is a cystic lesion with marginal enhancement. Sometimes you can use the help of diffusion weighted images to differentiate between both lesions, since you can easily appreciate the diffusion restriction in cases of pituitary abscess compared to the free diffusion in cases of pituitary adenoma. And this is an example where you can see this is a mass in the pituitary gland, and there is before contrast enhancement. After enhancement, you got a thick marginal enhancement, which may suggest the presence of a pituitary abscess. You remember the Russell's cleft cyst, which is a cyst arising from the craniopharyngeal duct. This craniopharyngeal duct is a duct which connects the nasopharynx to the intracranial structures through the cellular floor. The duct usually involutes during the fetal life, but sometimes it may persist, leading to the formation of this Russell's cleft cyst or the craniopharyngeal duct cyst. This cyst is a lesion predominantly located within the pituitary fossa, and it may extend in the supracellular area. It has an epithelial lining, and it contains fluid of similar CSF density, being of low signal in the T1 and high signal in the T2. Sometimes this fluid is colloid, and it may show some brightness in the T1 weighted image, but this cyst do not show calcium, and this cyst do not show enhancement. If any enhancement occurring in this cyst, it may be in the form of thin marginal enhancement, which can differentiate this lesion from the craniopharyngioma, as I will mention. Also, I mentioned that the typical location of the Rossix cleft cyst is usually immediately below the attachment of the infundibular stalk to the pituitary fossa and to the pituitary gland. Then you see a small cystic lesion, which is immediately below the level of the infundibular stalk. And also you see here, although it is possible that a small cystic adenoma could have this appearance, and this is very typical location for Rossix cleft cyst. As I mentioned, it is related to the infundibular stalk. Then this Rossix cleft cyst has no solid component to differentiate it from the craniopharyngioma. The Rossix cleft cyst is predominantly an intracellular pathology, while the supracellular, craniopharyngioma is the supracellular pathology, and also it will show no enhancement or minimal marginal enhancement. And this Rossix cleft cyst usually displaces the infundibular stalk anteriorly. Then in the pituitary region, as well as in the orbit, and in many areas in the head and neck, metastatic deposits can be seen. And metastasis to the pituitary gland is a known pathology, although it is rare. And also metastasis to the infundibular stalk, metastasis to the optic chiasm, metastasis to the skull base, all these are well-known pathologies. Then metastasis to the cellular area may occur in the supracellular, in the paracellular, or in the infracellular area. And the term pituitary carcinoma is extremely rare, and most of malignant pituitary lesions are secondaries to other primaries elsewhere in the body. Metastasis to the pituitary gland may present by diabetes insipidus, which is considered rare with adenomas, may present by panhypopituitarism or multiple cranial nerve pulses. Then in order to diagnose metastasis to the region of the pituitary gland, a known primary malignancy should be identified in the history. Then this patient had a breast cancer, and there is a big mass in the region of the pituitary gland, mostly inferior to the pituitary gland, in the region of the sphenoid sinus, and there is a convex upper border of the pituitary gland with midline position of the infundibular stalk. There is evidences of extension into the cavernous sinuses bilaterally. And this is also a patient with bronchogenic carcinoma having a mass involving the region of the pituitary gland centered to the cellular floor, and it is inseparable from the enhancing pituitary tissue. It also infiltrates the sphenoid sinus with destruction of the roof of the sphenoid sinus, and also there are some retained secretions within the left sinus compartment. This is the end of the first part of my talk. Alhamdulillah Rabbil Alameen, wassalatu wassalamu ala Rasulihil Kareem.